Welcome to Grand Rounds. I'm Bruce Luxon, and we have a fantastic speaker today. I'm going to introduce her. She's a member of our Pulmonary division. Dr. Gross went to medical school in New York at the State University of New York. She then moved to Philadelphia, where she did her residency at Thomas Jefferson, a fellowship at the University of Pittsburgh in pulmonary and critical care. And then after her fellowship, she was at Cooper University, where I think she started developing her expertise in asthma, and she was director of the Asthma Center there. We were able to recruit her to Georgetown following that, and she's remained a member of our faculty as an associate professor. When I looked through her resume, I noticed that she's gotten multiple awards in education issues. I'll just mention a few before I turn it over to Dr. Gross. She's specialized in supportive care and training programs. And finally, she's gotten multiple awards, including international awards, to travel to tell others and teach others how to be leaders in education. Dr. Gross.
Thank you, Dr. Luxon. So today I'm really excited to talk to you about asthma. And I hope that you do not walk out of this talk more confused than you came in, because there's some discordant information out there, and I think we have to just really be good clinicians and use our best judgment. These are the objectives. By the end of the presentation, the learner should be able to understand the pathophysiology of asthma, describe the SMART approach to asthma management, and list novel therapies for severe asthma that are adjuncts to a comprehensive approach to asthma management. And so I just found this online. Some of you might recognize our fellow Shruba, who is working locally. And Shruba had the opportunity to lobby on the Hill for the American Thoracic Society Hill Day. Remember when we used to lobby on the Hill? So here she is shown with the president of the American Thoracic Society at the time. And what's really neat about Hill Day is that before we go and lobby, we generally get a talk by Dr. James Kiley. And this is really interesting because I remember Jim talking well over 5 years ago about all the advances. He's the director of the Division of Pulmonary in the NHLBI at the NIH. And so I remember him specifically talking about the fact that there were so many new studies out, and they met as a group, and did they think that it was reasonable to update the National Expert Report from the NHLBI on asthma, the last one having been done in 2007. The first one was in 1991 and really changed our practice. And the answer was yes, but we went all these years without this information until really last week. What Dr. Kiley was talking about was the NHLBI guidelines, but there's also the Global Initiative for Asthma Guidelines, which are updated about every year. And so really, the changes that I'm going to talk about started appearing in the Global Initiative guidelines, of which we have representation from this country, from CHEST and internal medicine and the American Thoracic Society. But there are, as I mentioned, there's a little bit of discordant information. So we'll talk about pathophysiology and treatment, and then the recommendations. And so just to tell you, there are probably about 300 million cases worldwide of asthma, and we think probably at this point more than 26 million in the US, of which half are allergic and anywhere from 3 to 10% are severe. May I ask, are the slides advancing appropriately now?
Yes, they are.
Thank you. Okay. And so one thing I just want to point out, and this is just such a big topic in medical schools and medicine in general, and is the fact that there's so much with regard to health disparity and racial differences with utilization, mortality, even within race and ethnicity, depending upon where patients live and where they're from. If you look at the Latinx population, you'll see that there's such a high incidence in Puerto Rico versus Mexico. And so there's so much that we really have to learn about this still. And I think that the attention of medical institutions as a whole and the understanding that our education up till now has been sort of embedded in a white supremacy model, I think we're really going to start to see some changes now. I hope so. And then this is not a COVID map, obviously. And so what you see here is that depending upon the state and the region, in some cases has to do with access to healthcare, and others has to do with smoking, or just family lineage, there's going to be difference in prevalence of asthma. But the interesting thing is that with regard to severe asthma, you can see how much of the GDP is actually spent on the disease itself, but most of it, as in any disease, goes to those who have the most severe disease. So it's always good to start with a case. A 35-year-old female with a history of childhood asthma presents with cough, dyspnea, and wheezing. It's worse in the spring when she's outside, when she exercises as well. She has a history of eczema, rhinitis, and her mom has asthma, as do her sisters. So this is really easy, right? Like, you know, this is pretty simple. So first, let's just decide what we're talking about. And this kind of changes over time. So we used to say it's a problem of bronchoconstriction. Then it's a problem of hyperreactivity or airway irritability. But it's really a disease of inflammation because not everybody has hyperresponsiveness. It's generally in the lower tract, although the upper can certainly be a trigger. These are the symptoms. Generally up front, airway obstruction is going to be reversible, but then over time may be irreversible. And then you may have these underlying issues. And I presented this to you a few years ago when I presented at Grand Rounds, just to explain that there are different phenotypes. And it's not of asthma, it's not really as important up front to identify that phenotype as it is as we find that patients become more refractory to treatment or they have more severe disease, because it's knowing those phenotypes and endotypes that can help us choose our therapy for our patients. These are the ones who scare us the most, generally the discordant inflammation, where they really have, you know, many studies have demonstrated that patients, particularly with severe asthma, have a very poor perception of the degree of obstruction or inflammation, whereas obese females may be non-eosinophilic, may present later in life, may be a little bit harder to treat. And so we know that we have this genetic background and that exposure to our environment over time is going to result in subtle epigenetic changes. We do know that asthma is more prevalent in boys in childhood, but then becomes more prevalent in women than men over time. And it has a lot to do with exposures as well. So, you know, we're breaking up asthma now into T2, and we're talking about the T2 lymphocyte, T2 high and T2 low. And so really what happens is that an antigen presenting cell, usually a dendritic cell, will present an antigen or an allergen to the Th2 cell that is going to have several effects on the epithelium. Thymic stromal lymphopoietin is pretty important. We find there's exhaled nitric oxide. We stimulate eosinophils. That results in
compensation here, but it's a primary
that results in
alkalosis, metabolic.
Thanks. That results in release of things like eosinophil cationic protein. There's isotope switching, so B cells stop producing IgG and IgM and start producing IgE. There's prostaglandin inflammation. And so some of these mediators may affect other cells or may directly. We used to think that the smooth muscle cells were just innocent bystanders, but it turns out that they're pretty twitchy too. And then there's the T2 low, where you may have NK killing, the innate lymphoid cells, interferons may be more important, neutrophilic inflammation, and these might be patients who are less likely to respond to our routine anti-inflammatory medications like inhaled steroids, which are always the first approach to treatment of these patients. And so that's going to result in a characteristic pathologic pattern where you have smooth muscle hypertrophy, you have increased hyperplasia and hypertrophy of your mucus-producing cells. You'll have sloughing of your epithelial lining so that patients can often cough up green sputum that looks for all the world like it's an infection or acute bronchitis, only they don't have any infectious symptoms. And so you'll have these changes and then ultimately keep filling and keep swelling with airway edema, and then your nice open airway goes to this closed one, which the smooth muscles will then constrict, and then ultimately you can see how if you were to use a beta agonist to relax these smooth muscles and open up this airway over time, it's going to become harder and harder. And so just a word about airway remodeling. There may be some populations who are predisposed for that to happen, or there have been some studies on way back looked at uncontrolled airway inflammation, and sometimes there's subepithelial fibrosis, there's angiogenesis, so that this may ultimately result in a persistent airflow obstruction, regardless of what we do. And that's really what we look for on our pulmonary function tests. So this is a flow volume loop, the expiratory flow. And I've told you before, one of my colleagues once said, if you can sit on it, then it's obstructed, because it should come straight down like this. And as I mentioned initially, the airflow obstruction will be reversible, which on pulmonary function test is an absolute change in the FEV1 or the FVC to inhaled short-acting beta agonist of 200 cc's and 12% from initial. But ultimately that can be fixed, that becomes fixed, and then patients get air trapping. And we can see that in many ways. In an exacerbation in the ICU, we may have a patient who is air trapping or on a ventilator, auto PEEPing, and may have decreased venous return to the heart. It may be bad enough that they get hypotensive, for example. Or the patient feels like they can't take a good deep breath, but it's really because they haven't exhaled and they have air trap, that if you take a full breath and hold it and then try to take a regular breath on top of that, this is going to be really hard. So if pulmonary function tests are normal, there's a variety of approaches that we may take. One may be looking at nonspecific bronchial hyperreactivity, using methacholine, which will directly stimulate these twitchy smooth muscle cells. Sometimes we can use eucapnic hyperventilation, hyperosmolar saline, or an exercise study. And so with nonspecific, with methacholine, we're generally looking for the PC20, or the provocative concentration that drops the FEV1 by 20%. If your airways are really twitchy, then it's going to take a very low dose of methacholine to cause a fall in FEV1. But if your airways are not, or you're on inhaled steroids, for example, then you can keep doubling the concentrations of this methacholine and it's not going to cause a drop. That may or may not be the right thing to do. Sometimes you may choose to do exercise testing if somebody only has symptoms during exercise. An exercise challenge would subject the patient to exercise, and then serial spirometry following the exercise test to see if that falls. Or perhaps you need to do full cardiopulmonary exercise testing, where you have a patient, we assess the patient to see whether or not there's a vascular limitation, which includes cardiac or pulmonary vascular issues, a ventilatory limitation, or maybe none at all. Maybe the patient's just deconditioned. So, depending upon the person whom you're seeing, if it's a 60-year-old with a history of hypertension, diabetes, overweight, you may not jump to the asthma diagnosis, even if the patient had childhood asthma. Whereas if it's a college student, a 25-year-old coming in with symptoms, you may want to go down that asthma path. This can be really challenging if you have a seasoned athlete. Sometimes they just blow the tests away. They just do really well and you have to empirically treat. Now, this has been around for a while and we've explored purchasing them, and a couple of times we've done this and then we've opted out. And so I think that with guidelines, it's a little hard to say. So the epithelial cells, when they're inflamed and they slough, they'll secrete nitric oxide. So there's like reactive oxidant injury. And so understanding that there are limitations in the latest guidelines, NHLBI, conditional recommendation, low to moderate evidence. And it should only be used, I had to read this paragraph a few times, only be used as an adjunct to diagnosis and an adjunct to monitoring. There are plenty of studies that demonstrate that using exhaled nitric oxide helps step down inhaled corticosteroid therapy, but there are equally controversial studies that show that that is not the case. And some of those reasons may be that if you have upper airway inflammation, that can give you a higher exhaled nitric oxide. If you have obesity or tobacco use, you may have a lower exhaled nitric oxide, and we have a pretty good population of overweight patients. Fortunately, not as much in tobacco use. But what is said is that if you have a super low, like 20 parts per million exhaled nitric oxide, you may want to consider another diagnosis besides asthma. So our patient has mild obstructive ventilatory defects, so we believe she has asthma, and she clearly has a phenotype. Wake her up twice a month. She uses a short-acting beta agonist 3 times a week. So then in thinking about what the treatment might be, one thing is, so first of all, we're always going to use education, but one would be trigger control. Are there dust mites in the house? Are there other pests like rodents or cockroaches? Fluffy, who sleeps in the bed, and try to get a patient to say not to keep the pet in the bedroom, especially with people at home all the time. It used to be when they came to work, even if they kept the pet out of the bedroom, which is where they spent most of the time, that might help. But now so many people are working from home. Odors, sulfites, pollens, grasses, ragweed. And so it's, as I mentioned, it's important to educate. So if I have a patient who has known dust allergies, I will generally refer them or print up something from the American Lung Association just in terms of education for dust mites and how to minimize them. And so in the latest iteration of the guidelines, specifically NHLBI says multi-component allergen-specific mitigation, meaning you're not only going to tell patients to get mattress covers if dust is a big problem. You're going to talk to them about whether or not they have hardwood floors or carpeting, for example, if there are any pests, and then subcutaneous immunotherapy only in the NHLBI guidelines, although interestingly, it was printed in the allergy, published in the allergy annals, the Journal of Allergy, Clinical Immunology. GINA differs and says that you can do sublingual treatment if you have dust. But I want to also mention something about GINA, which is very sensitive to just healthcare disparities, and where we're always scientific and we would really like to go by testing. That's not always available for patients in low income socioeconomic level areas. And so we might just have to go based on history and give the patient the benefit of the doubt. I'm a little disappointed that the NHLBI said you should keep the animal out of the house. And I just think about all these people just leaving their animals outside, but that's another story. So as I mentioned before, we always start with inhaled corticosteroids. They have many effects on cells, but don't do anything for leukotriene. So we'll stop transcription and translation of many pro-inflammatory mediators. The leukotriene pathway, which, you know, if it works in patients, it's fantastic because it can affect both upper and lower airway inflammation. We know for sure that leukotrienes are potent inflammatory mediators and cause bronchoconstriction. It's just that a lot of people don't respond. So it's not really a medication that we're going to go to up front, and is typically in the guidelines listed as an alternative medication. In the old days, it used to be that it had clinical equipoise, it was thought, using low dose inhaled corticosteroids, but now we know that that's not the case. Just in terms of other triggers that may be treated, so the ARIA or ARA guidelines came out, I think the last was 2016, in upper airway inflammation, and there you can find information on whether or not you should use antihistamines. Usually they're going to go with nasal steroid over local nasal antihistamines. And one other thing I would mention about a trigger, which should have been the previous slide, was reflux. So we know for sure that treating asymptomatic reflux is not helpful, but symptomatic reflux is definitely helpful. Our bronchodilators, we really don't use theophylline because it's got that low therapeutic window, but we know that short acting, although they take effect later than beta agonists, so we tend to use beta agonist as quick relief medication. Now there's information on both LABA and LAMA. This is one of the earlier studies. It's kind of interesting because this is when we were looking at asthma control, but everybody was so interested in peak expiratory flow and FEV1. And, the paradigm of asthma has changed, and really we look at the patient as a whole person. And if they have persistent symptoms but have a better FEV1, does it really matter? And so the latest iteration of the guidelines have said that they prefer ICS LABA, long-acting beta agonist, over LAMA, the anti-muscarinic. But if for some reason you can't use a LABA, like say you have a patient with AFib with RVR who can't really take beta agonists all the time, then certainly adding a LAMA to the inhaled corticosteroid is very helpful. And it's also good for step up. So you can add LAMA to the LABA. As I mentioned, deciding what endpoints you're going to choose I think that research has really changed, which has really helped our patients a lot. And then finally, the biologics. As I mentioned, you have your T2 low and your T2 high. And so we have these medications that will work on IL-5. We have many that are in study. Omalizumab, which binds to free IgE, was the first. And so moving down the line with IL-4 and IL-13 is dupilumab. We can talk about that in a little bit of detail, but not too much in a bit. And then just to also add bronchial thermoplasty, we have that here. The trials had looked really good, even 5 years out, except for the fact that, so what this is radio frequency will help zap the airways. It's 3 separate appointments. And what it does is that remodeled muscular layer, smooth muscle layer, it kind of zaps that. So the airway remodeling is less of a problem. So we don't know about long-term effects, but there have been some short-term effects that result in admission to the hospital, exacerbations that last a while, lung abscesses, just kind of quite a bit. So then this says individuals who place a low value on harms and a high value on potential benefits and quality of life might consider. So I really don't know too many people who place a low value on harms unless they're so symptomatic that they've tried everything else and it really, really doesn't work. And so just something to consider. And it might also be helpful if your patient isn't really an eosinophilic asthmatic because they're not going to respond as much to the other medications. And then just to throw out there that in the lungs, as in every other organ, there are opportunities for working on the microbiome. It may play a part. And so macrolides can also be used for severe asthma. But one thing to think of is that there may be some resistance. There may be an issue with atypical mycobacterium. Sometimes some of our patients have bronchiectasis and not really asthma. So it's just something to take into consideration. So, it's really important. Teamwork is so important. And we explain this in great detail to our patients. Particularly those with moderate to severe asthma should have some kind of asthma plan where they have some prednisone at home. They know they may monitor their peak flows or their symptoms. And everybody's a little bit different. Like the neutrophilic asthmatics are going to go rapidly from like 0 to 60 in a second. And they just, they just decompensate. Whereas your eosinophilic asthmatics are going to kind of percolate along. And so you may have a little bit more time. They may notice their peak flows are going down. They may notice more symptoms. So that'll give them a little bit more time to intervene. And so we want to, a lot of these patients are young and it's really hard for them to accept that they have a chronic problem. And so, kind of looking at the patient as his or her own primary care provider may be helpful. And certain patients, it may help them with peak flows because, there may also be patients that you really don't feel comfortable having them manage an asthma plan, asthma action plan. It could help them tease out if it's just reflux or anxiety and their peak flows fall. But you may also want them to just call you, whereas other ones have said, oh yeah, I got the flu, my wife had the flu, I had the flu, I had some asthma symptoms, I took some prednisone, and hi, nice to see you for my follow-up. So it's, kind of a patient by patient thing. So there are issues with the guidelines. So I showed you Jim Kiley. And so what happened with the NHLBI was that they came up with questions in 2014 and they narrowed them down to only 6. And during that time, biologics really took off. And it's such a big part of what we do with asthma right now, but they don't really address that at all in these guidelines that were just published. They also mention the leukotriene receptor antagonists, but they don't go into detail in studying them and just kind of say, well, they don't work as well anyway, so maybe we'll save that for another day. So it's sort of like anything else. By the time that guidelines are published, it's already time to update them, which is why the GINA guidelines, I think, are pretty helpful. So, in thinking about our patient, we will look at the severity of asthma initially. And then, we're looking at the severity in terms of the impairment. We look at control, I should say, in terms of impairment and risk. So up front, we look at severity, and that's just based upon the frequency of symptoms, either nocturnal or daytime, and pulmonary function. And whichever one is the most severe, say you have mild symptoms but worse pulmonary function or vice versa, will put you in the more severe category. So our patient really would have been in the step 2. One thing that they have noted recently is that even if patients, particularly kids, are doing so great in between exacerbations, but they start to have at least 1 or 2 a year, it automatically puts them into the higher category. And the important thing is to realize that this fluctuates over time. These are a couple of studies way back, CHIPS in kids and Calhoun in adults, looking at, this was over a 12-week study, how at any one time, patients with severe asthma may have been diagnosed with mild asthma. So their severity kept shifting. So, their control kept shifting. So realize that when you're seeing a patient for the first time and you're trying to assess their severity, that may be just a point in time. And so the newest guidelines, particularly GINA, will keep telling us to go back and recheck pulmonary function tests and just make sure, especially with severe asthma, that's a retrospective diagnosis on how the patient's been doing in the past few weeks, particularly with regard to the interventions. So you will have access to this. It is online in the JAMA, the latest JAMA. It is online at NIH. The GINA, Global Initiative for Asthma, guidelines are available for free online also, and there's a pocket guide. So I'm not going to go into this too deeply, and you can take a look at the alternatives, but we can just basically talk a little bit about what the preferred treatment is. And remember, with regard to using the SMART approach, which is using inhaled corticosteroids whenever you use a bronchodilator for relief, right? So you have your controller therapy daily or your relief therapy. And so if a patient has acute symptoms, we may decide in 2 to 6 weeks to have them come back. If they're not stable and we have them stable with regard to symptoms, pulmonary function, then we might wait 3 months before stepping them down. So we just don't want to do it too quickly. And it's important to tell patients up front, they had an exacerbation, then by all means, they can go back sooner. But it's important to tell patients up front, look, it's recommended that we keep this for at least 3 months. So if you're starting to feel better, please don't discontinue this medication or decrease the dose unless talking to me. We can have a good conversation. So what they're saying is in the step 1, where the patient has intermittent asthma, using a PRN, short-acting bronchodilator. In step 2, where our patient would have found herself, either daily low-dose inhaled corticosteroid and an as-needed SABA, or whenever they're using as-needed SABA, you add an inhaled corticosteroid, okay? As time goes up, they're suggesting that you use daily and, as symptoms become more severe, daily and PRN combination, low dose and Formoterol, low dose ICS and Formoterol. So that's a combination of inhaled steroid and beta agonist, both short and long, and I'll show you. As you get to step 4, you're stepping it up, but you're using it again daily and as needed. And then by the time you get here, you're using higher doses, and you may be throwing in long-acting muscarinic like tiotropium, and then here patients may be on corticosteroids, and then they sort of mention as a footnote to consider adding biologics or subcutaneous immunotherapy. So this is Gina, which I think, for me, I'm a simple person, so I really like this one. But you confirm the diagnosis, as we mentioned before, you address comorbidities, and you look at symptoms. And in this case, step 2, the patient would have been on daily low-dose inhaled corticosteroid, or just the low-dose ICS as needed before. But in step 1, the intermittent, they're saying here low as needed combination. So we know even with intermittent, they do better if you give them inhaled steroids, but it's really hard to convince patients that that's really the right thing to do. You can always add a short-acting beta agonist. If you use a lot of short-acting beta agonists, you have downregulation of the receptor. And so, as you can imagine, several drug companies went a little ballistic when their drugs weren't mentioned. So Gina had to put out firmer guidelines and say, well, if you're on inhaled corticosteroid and salmeterol, for example, you might use a SABA, or you might use a SABA with an inhaled corticosteroid. So as you can see, it's a little confusing, but you really want to make this about the patient and decide what the best thing may be for the patient. And so the big changes have been this combination. They say also not to increase inhaled corticosteroids for adherent patients. So there was, initially we used to say double your dose of inhaled corticosteroids. Then there was studies that showed that quadrupling your dose of inhaled corticosteroids for an exacerbation may be helpful. But that is not really helpful if you think you have an adherent patient. If you have a non-adherent patient, just giving them the inhaled steroids, whether it's quadruple or anything, may be helpful. So you have to take that within context, and it has a lot to do with the language. You know what? If I have to take antibiotics, I have a really hard time remembering to take my antibiotics or my medication. Is it possible that you might have missed some doses? And they'll say, yes, I have. So for moderate severe, as I mentioned, the combination daily and PRN, And then severe, as I mentioned, is a retrospective diagnosis. And I recall this study in 2007, and I remember reading it in my geeky manner and thinking, wow, but being too wimpy to actually implement it. So this was looking at as needed combination with inhaled corticosteroid and long-acting beta agonist, regular, and then as needed albuterol therapy. And you can see that as needed combination therapy worked super well. It wasn't powered for exacerbations, and as I mentioned, they questioned, this network questioned, were we looking at the real endpoints? And so Formoterol, unlike salmeterol or the other ones, although some may be coming out that have short acting, they have a rapid onset. So it's really nice if you have patients on the combination, when they wake up in the morning and they would normally need their inhaled beta agonist, if they take this, they're going to get short and long acting. And the maximum in the GINA guidelines was 72 micrograms of the beta agonist, and in the NHLBI guidelines, it's 54. This was, so SMART stands for single maintenance reliever therapy. This was the practical study. There have been 4 studies essentially that have demonstrated that the SMART approach to treatment has been very helpful. This was an open label study, but it was kind of interesting because it really seemed like it was more of a real-time study where patients just used the medication as they needed. And if you think about it, one reason to not start patients on short-acting beta agonists alone might be that they actually feel better. And even though it's potentially harmful, right? Beta agonist effects on the heart, downregulation of the receptor, it's very hard when they come back to you and they're feeling great and you're like, oh, but your pulmonary function isn't that great. I'm not hearing as good airflow, to convince them to take inhaled steroids because you've already told them, take this medication and you'll feel better. And then the other thing is that even those patients on inhaled corticosteroids probably aren't taking them, so why not just take them together? And so this was the looking at this study, the practical study really favored budesonide, and ACQ is one of the asthma control tests that you can do, the asthma quality of life questionnaire. We look at the asthma control test, which is a 5-question questionnaire. One thing that was really neat about this, if you're thinking about problems with steroids, glaucoma, if they go on oral steroids, it could even be thromboembolism or diabetes, inhaled steroids, obviously with osteoporosis. What they found was that the dose was significantly smaller in those patients who only used as needed, and they did not have more exacerbations. In fact, they had less. So let me just tell you about my experience. You know what it's like when they call you or they send you something and they say, your patient's formulary has changed, so you have to change every medication that they're currently taking. Well, imagine what it's like when the pharmacist reads, take as needed inhaled steroid and long-acting beta agonist, or take twice a day and as needed. And I've already taken to, in the instructions writing in parentheses, this is not an error. Or because they called me, when GINA came out in 2019, I was explaining to them that this is really the way that we are treating now, the asthma now. So I'm hopeful now that the NHLBI guidelines have come out, that pharmacists and pharmacies will know that this is an issue. I don't know how lucky we're going to be in getting them to use only ICS LABA combination. So it may be that we have to, we have some down the pipeline, but we may have to give an inhaled corticosteroid and a SABA, short-acting bronchodilator. So, some of them will not pay. So if you gave a combination fluticasone and salmeterol, then you have to make sure that they take 2 inhalers when they're having symptoms. So good luck. So we talked a little bit about control, that's risk and impairment. And so we use pulmonary function, but again, we're using this asthma control test, which is really easy for your patients to fill out while they're waiting for you. And anything less than 20 means that they're poorly controlled. And so it's very humbling. A lot of times we'll think patients are doing really, really well, but when you see this number is like 12, you have to go back and try to figure out what's going on. Maybe it's just upper airway inflammation, but maybe it's asthma. So we'll move on to a different case because I wanted to just touch on severe asthma a little bit, and exacerbations are for another time. You know, we all know about oral corticosteroids, bronchodilators, and whatnot. But so this is a 52-year-old male with longstanding asthma, presents with asthma that he says is refractory to treatment. He's a scientist. He has perennial symptoms. He thinks he has a dust allergy. His peak flow is 50% of his best. And that's the key, is we always do personal best if they're monitoring peak flow. He's had a hospitalization this year, but he's had others in the past. His asthma control test score is 10. We said anything less than 20 is not well controlled. And we think he has severe asthma. And so, you know, there's uncontrolled asthma. There's difficult to treat asthma. That doesn't mean the patient's difficult. It just means the patient is taking all the medications we think the patient's taking the medication and is still having symptoms. But what's really interesting is when you look at refractory or severe asthma, patients may not be taking medications properly, either intentionally they can't afford it, unintentionally because they're using their inhaler wrong. And the 88% were patients who in this study were actually not adherent, all of them after having said that they were compliant and adhering to the treatment. So, you know, this was done under study conditions, and still they had to go back and kind of press the patients. And sometimes using that language that I mentioned before and being very empathetic can help. The things you need to think about are phenotypes. We talked about the different ones. Neutrophilic, there may be very few cells. It could just be hyper-responsive, and maybe these patients are the ones who have airway remodeling. There is a degree of steroid resistance in some patients, and you know, we talked a little bit briefly about transcription and translation of inflammatory mediators. Histone deacetylase, for example, once the complex moves through the cell, this can be affected in smokers. So we find that smokers sometimes are refractory to asthma treatment, to steroids, I should say. And so it's also important to recognize why patients are at risk for death. And I don't sugarcoat it. If I have patients who've been admitted and intubated quite a few times, I say, I'm really, really worried about you because these are risk factors for dying. And so this is a cast of an airway. The patient basically asphyxiated. And so, you know, we hear about people, I don't know if you recall, but one of our respiratory therapy supervisors died of an asthma attack many years ago here. And so it's really important to recognize all of these and you know, think in terms of outreach. What really do we need to talk about? What's going on in their lives, especially now, I would say, right? And it's important to identify the barriers to care. This is the privilege gap in medicine, which we're certainly hearing more about, but I've been using in my my talks for many years right now, that so many of us come from higher socioeconomic levels, but a lot of our patients don't, and we really need to realize that. And this is years of life lost due to asthma. We know all about zip codes, you know, just a few miles apart, having 15 to 17-year life expectancy differences. And so you can see this is the lowest, the highest years of life lost, and there's a lot to do with that. You know, there's not only food deserts, but there's also lack of access to healthcare, health literacy. You know, it's really important to use that teach back method. You say one thing, if you say attack or exacerbation, they may not understand what you're talking about. So sometimes flare up works. untreated patients may present as severe and irreversible. And sometimes in those areas, providers don't know a lot. So we've kind of done some health equity work at the American Thoracic Society, reaching out into these physicians to educate them. One thing you want to think about always is that there's occupational asthma. It can be really sad, somebody working with animals who is all of a sudden sensitized to the antigen in rat urine and is a supervisor of a lab. We want them to get other jobs, but that's not always possible. Asthma with coexistent with COPD overlap syndrome, you may approach that one way or another. If it's more asthma, you may go down the inflammatory route. Whereas if it's more COPD, you'd start with bronchodilators, but realize that this is an inflammatory disease as well. Comorbidity, so if they're constantly producing a lot of sputum, bronchiectasis is an issue, and allergic bronchopulmonary aspergillosis or cystic fibrosis. We all know that adults can be diagnosed later. Is it one or the other, or sometimes both? Vocal cord dysfunction, now called inducible laryngeal obstruction, as postnasal drip is known as upper airway cough syndrome. So we have more sophisticated names for these diseases. Obesity, certainly asthma is worse. It's an inflammatory disease, or does a patient have CHF? So we don't want to anchor on one diagnosis. I'm not going to belabor this. You can go and look at the GINA Pocket Guide, or if you want to look at a couple of hundred pages, you can look at that too. But this is just a really nice way of approaching our patients with severe asthma once we believe they truly have severe asthma. First get to the diagnosis. One thing is, if your asthma medication, if somebody comes to you for the first time and they've been given treatment, which is not totally the wrong thing to do by another doctor, they may not have asthma. And so there are stages, there are distinct guidelines on how to step down that treatment and keep testing your patient until you may get them off their asthma medication, which happens all the time, and they have another problem. It's not really asthma. So obviously, if symptoms return when you step down therapy, if they're on oral corticosteroids, remember, everybody feels worse when you stop it. They feel great when they're on steroids most of the time. And then sort of thinking about which patient might fall into one or two of these categories, and going down and constantly, looking at the payer mix. I may decide that one patient, one biologic agent is the ideal biologic agent for my patient, but they say, too bad, we only have the other one on formulary. And so it's that or nothing. And so you have to then decide, is it really appropriate? And then just showing you what is available right now. I did show you a little bit before, and what's currently being studied. So this is pretty exciting. We had the same treatment for asthma for so long until we had omalizumab, but now we have all these other medications. So Reslizumab is, and I'm not going to go over these in too much detail because it just dilutes the information, I think. But Reslizumab is, an IV medication. Here they looked at FEV1, which is kind of neat because looking at, usually it's the bronchodilator companies that look at the FEV1, but you can see here, this is the absolute eosinophil count. So, in terms of thinking about immunotherapy or biologic, you may do like a total IgE. One thing about this is they're eosinophilic disease. Before you'd want to start any of these medications, it's not a bad idea to check for parasitic infection, especially in patients who are from endemic areas, as we've been finding also with treating COVID. Benralizumab, also an IL-5 receptor. And so this is kind of a nice medication, subcutaneous, because it's every 8 weeks, which is the longest therapy. Dupilumab, which is the IL-4 receptor, also affects IL-13 that works on eosinophils. And so some, for example, dupilumab, you don't need to have a high eosinophil count. If you're on oral corticosteroids, that may be the trick. If you have bad rhinosinusitis, Reslizumab or dupilumab may be helpful. If you have eczema, really severe eczema, dupilumab. Mepolizumab, which is an IL-5, can be good for eosinophilic granulomatosis and formerly known as Wegener's. So, and it's not to say that only one works for any of these things. It's really what the drug companies have tested for. So when you're thinking about choosing, you may think about at that point, what is the phenotype of my patient, and then choose based upon that, or the formulary. Or sometimes patients just simply can't get it, and they can't even get long-acting beta agonists or combination therapy. And the copays can be really expensive, even if it's on the formulary or it's tier 1. Unfortunately, even trigger control nasal sprays are over the counter, and so they become very expensive for our patients. And it's such trigger control is such an important point of control. Just want to say something quickly about pregnancy, which is really just to treat the patient. Inhaled steroids, LABA, if they have really bad reflux, most of the PPIs are category B. When patients are pregnant is not the time to stop. It leads to problems in the mom and the baby. So just advise everybody to continue. And then just quickly, with COVID-19, a lot of institutions stopped checking pulmonary function tests, and now we're not doing methacholine challenge because they're worse aerosol generating procedures. For all our patients, if they're on biologics, oral corticosteroids or inhaled corticosteroids, we want them to continue. And inpatient or even, in the office, avoid nebulizers and use inhalers. So just a few things, just to remember how important it is to have a conversation, schedule a follow-up appointment, think about the culture and the education level. We're going to step down slowly. Objective measures, but not always if they're not available, and we have to take that into consideration and stress the team approach.